Also, let me just get organised here a bit more. I also want to bring greetings from the U of T Faculty of Dentistry. It's also good to see so many U of T grads in the audience here. In dental schools, in continuing education courses, in the dental literature, there's a particular emphasis, perhaps some would say an overemphasis, on some of the structural features of the craniofacial complex, teeth, jaws, how they move together, how structural changes can lead to problems with jaw movements, pain and so on. But as sort of Dennis was alluding to, hasn't been a lot of emphasis, or perhaps there has been an underemphasis on some of the biological and physiological processes that underlie pain and related. It's probably not necessary for most of this group to point this out, but let me point it out for those who may not completely appreciate it. First of all, pain is not a sensation. The sensation aspect of pain is just one of its dimensions. Pain is an experience. It's a multi-dimensional experience encompassing sensory, cognitive, motivational, and affective dimensions. The sensory dimension relates to the perception of the spatial and temporal features of a noxious stimulus. What do I mean by that? I mean, it's that perception of the location of the pain, the mechanisms related to the perception of the intensity of the pain, the duration of the pain, the quality. Despite these huge costs to the economy and to pain sufferers, pain also is often undertreated. There's a considerable amount of documentation now in the literature showing that opiates are underutilized for managing pain in many particular pain conditions. In post-operative pain after chest surgery, for example, is under-managed. And some have argued that sometimes pain is over-managed or over-treated. For example, in the use of some occlusal treatments, for TMD specifically. Why is this? Well, we think it's probably just because of a fundamental lack of appreciation and knowledge by many healthcare providers of pain, of its complexity, its meaning, and its mechanisms. And my job today is to try to help you understand a bit more about some of the mechanisms that underlie pain, particularly TMJ and muscle pain. I think most of you appreciate that pain is complex, and you'll see that the mechanisms, both peripherally and centrally, are very complex. It's also very common. Some of the most common pains occur in the orofacial area. The two most common pains in the body occur in this region: headaches and toothaches. And there's a 10 to 15% prevalence of toothache of TMD in the adult population. First of all, let's start in the periphery. Let's talk about the peripheral processes, the primary afferent mechanisms, in other words, mechanisms related to the innervation of the TMJ and craniofacial muscles. And I'll particularly focus on a process called peripheral sensitization, because peripheral sensitization is a peripheral process that contributes, as you'll see, to hyperalgesia, allodynia, and pain spread. Just to refresh your memory, if we look at a primary afferent nerve fibers, they're contained within a nerve bundle. So this is a nerve that's supplying peripheral tissues, tendon, blood vessels, skeletal muscle, skin, skeletal tissues, skeletal muscle, skin, viscera, and so on. And I'll remind you that it's particularly the small diameter afferent nerve fibers in the nerve bundle. It's particularly the small diameter afferents, some of the A delta, so-called A delta, which are small myelinated afferent nerve fibers, sensory nerve fibers, and the C fiber afferents, which are unmyelinated. These are the ones that terminate in so-called free nerve endings that are sensitive to noxious stimulation. They respond to noxious or tissue-damaging stimuli. So it's these A delta and C afferents, or some of them anyway, that are so-called nociceptive. When they're activated, they send messages along the afferent fiber, the sensory fiber, into the brain and signal pain.